Thank you very much. So I'm here to talk about recruitment guided by transpulmonary pressure, and I like to start this talk with a case. This is a patient we had in our ICU several years ago, post-traumatic ARDS, abdominal injury, chest wall injury, found in the morning on these ventilator settings. So controlled mechanical ventilation, lowish tidal volume, an FiO2 of 1, and a PEEP of 13. So how would you approach this patient? First off, of course, you would start with low tidal volume. This is the ARDSNet Kaplan-Meier curve of survival following low tidal volume versus high tidal volume. And that difference between the two curves is entirely attributable to preventing ventilator-induced lung injury. The question remains whether this mortality here is a function of the underlying disease or if there's more to be done in preventing ventilator-induced lung injury. And one way, of course, would be to recruit the lung and keep it open with positive end expiratory pressure. Now, there's a stack of animal experiments, some of which you were shown, suggesting that high levels of positive end expiratory pressure protect the lung and can prevent ventilator-induced lung injury. I won't go over these. Suffice it to say that the clinical trials have been disappointing. So there are several trials out there, and I'm sure most of the audience is familiar with them. Amado showed that a combined approach of low tidal volume and PEEP set by the lower inflection point benefited patients. That was confirmed in the ARES trial, but we really can't learn much about PEEP from those trials because one group had high tidal volume and the other low tidal volume. So that trial, we can't learn about PEEP. The alveoli trial by the ARDSNet was stopped early for futility. The Canadian LOVES trial showed no benefit. And the EXPRESS trial, which set PEEP to maintain a maximum plateau pressure, had mixed results, but really was considered negative. And in the Journal of American Medical Association that LOVES and EXPRESS were published in, Dr. Gattinoni and Caironi published this editorial, which I think was a very smart one. The LOVES and EXPRESS study should conclude the era of comparing PEEP levels in unselected populations and also underscore the need for a new definition of ARDS aimed at identifying patients with greater lung edema and lung recruitability. So I would put to you that this is a call for personalized physiology in the ICU, and personalized medicine is all the rage. But if we keep waiting around for DNA tests at the bedside, we'll never get there. We have tests we can do at the bedside right now to personalize our care. And the benefit of higher versus low PEEP really depends on the population in whom it's administered. So if I take patients and ventilate them with low tidal volume and I push the PEEP up, I get a negative trial, because there's two populations hidden in that study group. One are those who are non-recruitable. So by increasing the PEEP, I push the plateau pressure up by the same amount or perhaps even more. The driving pressure stays the same. The lung does not recruit. And in those patients, high PEEP injury outweighs the benefit. On the other hand, there are recruitable patients in there, patients in whom increasing PEEP recruits the lung. The plateau pressure comes down, the driving pressure goes down, and those patients, the benefit from high PEEP outweighs the injury. If I do a trial where I include everybody without trying to identify that green group, I will have a negative trial. So the trick is, how do we identify those recruitable patients at the bedside? So we have to go back a bit to the first principles of physiology. We've all gotten used to managing patients based on pressures measured at the airway, but that isn't the pressure which really interests us. The pressure that interests us is the transpulmonary pressure, or PL. And PL may be very different than airway pressure. PL is the airway pressure minus the pressure in the chest wall, or the pleural pressure. And many patients are going to have an elevated pleural pressure. Why? One, they may be obese. Two, they may have had a massive fluid resuscitation. Three, they may have an abdominal distension, abdominal compartment syndrome. There are many reasons why a patient in the ICU may have an increased pleural pressure. And unless I measure that pleural pressure or estimate that pleural pressure, I'm just not going to know what I'm doing with my ventilator. So how can we do that? Really, the only realistic way in humans is to measure the pressure in the esophagus. So this is our chief of respiratory therapy at my hospital, placing an esophageal balloon catheter into a critically ill patient. This is what that balloon catheter looks like. It's looped around. It's about the size or consistency of a piece of cooked spaghetti. And it's placed through the mouth or nose into the esophagus and placed in the retrocardiac position. Okay, the separate lecture on how to actually place those. When we place them, we transduce the esophageal balloon, and then using simultaneous recordings of airway pressure, of volume, of flow, we can then analyze those pressures for use. So this is an esophageal pressure measurement. This is a volume measurement. And here is a pressure volume curve of the passive chest wall that is derived from that. And the typical way this has been used in the past is to record the elastance or compliance of the chest wall, use that to separate the mechanics of the chest wall and the lung. But we believe, and there's evidence to support, that the actual measurements themselves are important. So the end expiratory pressure in the esophagus and the end inspiratory pressure in the esophagus have meaning and value at the bedside. There's some validation for this in the literature. This is a paper by Pelosi from 15 years ago. They took dogs, gave them ARDS, and placed pressure measuring wafers in the chest. So that's the gold standard for measuring pleural pressure. They then compared those measurements with pressures in the esophagus. And what they found is that esophageal pressure and pleural pressure are very highly correlated in the mid-lung area. So the esophageal pressure really does reflect pleural pressure, at least in one area of the chest wall. And it's not surprising that it's the mid-lung, because if I take these CAT scans of the dogs in the study and draw a line through their esophagus, you will see that the esophagus is more or less a mid-lung structure. In a human CAT scan, the esophagus is smack in the middle. So titrating our mechanical ventilation to that mid-lung portion actually makes a lot of sense. We avoid over-distending the anterior baby lungs. We don't fight to recruit every last alveoli in the dense atelectasis in the posterior area. We aim to recruit that mid-lung area. This is data that's since been published from Amato's group, showing a comparison between collapse on EIT, so this solid circles, and esophageal pressure measurements simultaneously. And here you can see that as the esophageal pressure becomes negative, you begin to see collapse on the EIT. So this indicates that anatomically also maintaining a positive transpulmonary pressure at end expiration seems to prevent alveolar collapse. This is a N of 1 study we did a few years ago. This is an obese patient under anesthesia. We're from top to bottom, we're measuring the airway pressure, the esophageal pressure, the volume delivered, and the flow. And here in the middle, we've disconnected the patient from the ventilator. So I'll zoom in on that area. The patient is disconnected from the ventilator. We reconnect him, and then we begin a slow inflation of the lungs. So you can see airway pressure beginning to increase. Now, as that airway pressure begins to increase, you can see throughout this red area, airway pressure is increasing, but no volume is delivered to the patient. There's no flow into the lung. Why is that happening? Because throughout this period, the transpulmonary pressure is still less than 0. Okay? The pressure delivered in the airways is not enough to overcome the weight of the chest wall pressing down. It's only when the pressure in the airway is greater than the pressure measured in the esophagus does the transpulmonary pressure become positive, and do we begin to see flow into the lung and an increase in lung volume? So, 3 bits of evidence which seem to suggest that these numbers actually mean something. So what happened to our patient? This is airway pressure, esophageal pressure, and then the calculated transpulmonary pressure. So that's the computer is deriving transpulmonary pressure. The patient's PEEP is 13 and their plateau is 40. The esophageal pressure is going between 20 and 33. This is an obese man with a packed abdomen and a massive fluid resuscitation. And the transpulmonary pressure is really low. So at end inspiration, the transpulmonary pressure is only 6. At end expiration, it's actually calculating as a negative number, meaning that the weight of the chest wall is higher than the pressure in the lung. That is going to collapse the lung, and that's why that chest X-ray is so whited out. So how did we treat this patient? We increased the PEEP from 13 to 26. That increased the plateau pressure from 40 to 46. And we remeasured. So with the new measurements, even though the plateau pressure is 46, the transpulmonary plateau pressure is only 12. Now, many of you would probably never get to these settings unless you had the backup and the understanding of what the actual transpulmonary pressure is. So this allows you to safely manipulate the ventilator on these difficult to ventilate patients. And this is a patient that I think in many centers might wind up quickly on ECMO because of inability to ventilate on conventional settings. And for what it's worth, this is the chest X-ray. It's very difficult for us in the US to get CAT scans on sick patients. Interestingly, if you look at these changes in the ventilator pressure, so a huge increase in PEEP, a moderate increase in plateau pressure, and when I calculate the driving pressure of the respiratory system, you can see that we've actually recruited this patient. So he would fall into that group of patients in whom high PEEP has actually functionally recruited them. And while a driving pressure of 20 is not great by any means, it's certainly better than 27. And showing that there was actual recruitment in this patient. So we turned this into a small RCT, and in this RCT, we randomized patients either to the ARDSNet P to F ratio table, or to receive PEEP to maintain a positive transpulmonary pressure at end expiration. Now, in one patient, that PEEP might have been 10. In another patient, it might have been 25. Okay, but the idea was just to maintain a positive transpulmonary pressure at end expiration. And this study, which was published several years ago, showed an improvement in oxygenation, which is not that amazing an outcome, but an improvement in compliance, a marginal improvement in dead space, and the sum total was these patients were ventilated with higher levels of PEEP, and the survival was not statistically significant, but definitely suggested that the esophageal pressure group wasn't harmed by these high levels of PEEP. This is a patient tracing from the current study we're doing. You can see this is actually a Canadian patient. The PEEP was set at 17 clinically. This gentleman was also pretty obese. The esophageal pressure was very high. So on 17 of PEEP, the transpulmonary pressure was negative. It was barely positive at end inspiration. So this patient was almost not being ventilated. And in this patient, they required 33 of PEEP to get almost to a positive transpulmonary pressure. So that shows you how high you can actually get using these measurements. Now, I will say conversely, there are also patients in whom we find that physician set PEEP is actually too high. And it's not uncommon for us to actually drop the PEEP based on these measurements without a detriment in oxygenation and often with an improvement in the hemodynamics. So I mentioned we can measure driving pressure at the airway, so the respiratory system driving pressure, but using esophageal balloons also opens up the possibility of measuring a lung driving pressure, a transpulmonary driving pressure, which may actually be a more significant variable. And what we've shown in this very small paper, very preliminary, is that the transpulmonary driving pressure probably predicts changes in elastance better than the respiratory system driving pressure. And these changes, this concept of transpulmonary driving pressure may eventually lead us to targeted tidal volume reduction in these patients, because up until now we've mainly explored the end expiratory side of the ventilator cycle. We haven't looked at limiting transpulmonary pressure on the end inspiratory side. So what happened to this patient's transpulmonary driving pressure? Again, a marked drop from 14 to 8. So to summarize, randomized controlled trials of PEEP, essentially a negative message for high PEEP, largely because there was no change in driving pressure between the two groups. And driving pressure, as we all know, has been shown to be highly correlated with survival. The only one that really did show a change in driving pressure was the EP-Vent trial. So I would put it to you that while obviously not perfect, there is no perfect method, it is the method that we can use at the bedside today to target recruitment to the patient's individual lung mechanics. And until we have something better, I would suggest that as much as possible, you go out, you try this, you get to know it, you become comfortable with the technique. If nothing else, you will learn a lot of respiratory physiology by playing with these balloons. Thank you very much.